Hi, this is Elliot Fishman, and welcome to Facebook Live. And whether you're on Facebook or on Instagram, it's great to be here. Today is January 2nd, so hopefully everyone celebrated a happy and healthy new year. And now we're back to work. It sounds or feels like it's Monday. I know many people have been off for like a week or 2 weeks, or it seems like a lifetime. I called up some of my faculty today to make certain they still knew how to read film since they've been away. And it does feel like a Monday, but today's Thursday, so Friday, and then you're off again for 2 days. Life is good. So let's get started. Just to give you a couple heads up in terms of CTisus, we have our newest upgrade to the lecture series, should be coming out in about a week or so. That takes the last 6 months of lectures, and now we're almost 500 lectures on the series. So that should be coming out within the next couple weeks. And also, we're finishing up the final edits. And again, it's at the Apple Store momentarily for our app using cinematic rendering for thoracic anatomy and vascular anatomy in the chest. So it's a terrific app that was developed based on an exhibit at RSNA, which did not win any awards, which shows they need to fire everybody on the exhibit committee or give them lessons on what things to give awards to. I know it's very hard to give awards because it's really not so much a bias, but it's hard to be fair. Maybe it'll be more fair next year. Okay, anyway, enough complaining. So you see right behind me, incidental adrenal masses. And that's going to be the talk for today. And I need to hang up my phone. And one of the most common things we see on CT are incidental adrenal lesions. And I know that it's often one of the biggest challenges for all of us. If you think about it, it's kind of interesting. If you think about, depending on the age of the population, depending if it's female or male, depending on patients who have diabetes, patients who are obese or not, if you take a 50-year-old, there's about a 7 to 10% chance they're going to have an adrenal lesion. And very much like those incidental splenic lesions, they're essentially all benign. And yes, I know we have adrenal carcinoma, and yes, we have metastasis to the adrenal, and yes, we have pheochromocytomas and other functioning tumors. But in a patient with no known malignancy, with no hyperfunction, meaning like hypertension, or the patient is Cushingoid or something like that, if you pick up an adrenal lesion, it's going to be benign. And just some of the classic rules. We talk about lesions 4 centimeters or less in size, though we all know you can have benign lesions that are over 4 cm. Think of myelolipomas. Think of adrenal cysts. Okay, so that's definitely possible. But the rule typically is this. If you have a non-contrast scan and there's a lesion 4 centimeters or less, and it measures less than 10 Hounsfield units, is an adenoma. And you can stop there. Those articles were written 20 years ago or more than 20 years ago. There's no need to go further. Now, one thing to remember is adrenal adenomas, even if they measure, let's say 5 or 8 or 3 on non-contrast, when you give contrast, they can enhance. So that's just a normal thing. So the challenge, of course, is what if you do a CT scan? We don't routinely do non-contrast. Maybe in kidneys we do, but you don't routinely do non-contrast abdominal pain or rheumatoid aortic aneurysm or things like that. What do you do when you see an adrenal lesion? And the adrenal lesion now measures 50 Hounsfield units and you're 60 seconds or 90 seconds post-injection. What do you do? So it's very important to realize that adrenal lesions will enhance and then they de-enhance. So they enhance and they wash out. And the articles have been very clear over time that the washout is from greater than 60% is going to be benign, with the one exception. Pheochromocytomas wash out more than 50 or 60%. The thing about it is, with pheochromocytomas, they also enhance more than 120 Hounsfield units on the 60-second images, arterial or venous, but let's say 60 seconds. Adenomas never enhance more than 110. So that's a very simple way of doing it. And by the way, we just let you know we are recording, and Lily's not here today. But Lily is saying hi from New York. I didn't know she went to New York. She must have been one of those 10 million crazy people who were watching the ball drop. I guess, I lived in New York for many years. I did not go anywhere near Manhattan. I hear that like once you get in the crowd, you can't get out. You have to be on water restrictions. You don't have to go to the bathroom. Otherwise, forget it. But hopefully she had a great time. Hopefully she's in New York right now, which is what it says. So hopefully she's having a great time. Anyway, so you think about adrenal adenomas. So now you talk about this washout. So when we think about adrenal lesions, we say under 4 cm, under 10 Hounsfield units non-contrast adenoma, stop. If you give contrast, and let's say it measures 40, 50, 60, 70, whatever, but less than 100, 110, then we look at its washout value. So you look at 60 seconds and 15 minutes. And what happens is the lesions wash out and need to wash out more than 60%. If it washes out more than 60% in 15 minutes, it's an adenoma. As I mentioned, the one caveat is if it's a pheochromocytoma. But again, that goes more than 110 or 120 on the early phase imaging. So that's pretty simple. So again, recognizing that most lesions are benign. The other lesion we see, which could have some vascularity, can even be larger than 4 cm, and we seem to see a lot of them are myelolipomas. Myelolipomas are older patients, which means they're often in the patient who has malignancy, and you're looking at the adrenal and saying, oh my God, is this a met or not? And myelolipomas are fat density. Sometimes they're all fat. That's really easy. Sometimes they're large and all fat and almost look like liposarcomas, and there was an article about that, and we speak about that in one of my lectures. Most of the time, there's enough fat in there and there's some swirls that there's no issue. The issue with myelolipomas, if there's any issue, it's not that it's pre-malignant, but they can spontaneously bleed. If patients have clinical symptoms or they're over 7 cm, most people say, some people even say 5 cm, they're going to resect it just because it's the easiest thing to do because of the concern for spontaneous bleeding. Once a lesion has bled, they're always going to resect it, even if it's on the smaller side. Now, the other thing you can see that's benign are cysts. That's pretty simple as well. Now, I mentioned malignancies, and the most common, but it's rare, is a primary adrenal carcinoma. Those are usually large, vascular, and aggressive. The most common presentation clinically would be Cushing's. And those lesions are smaller when they're hyperfunctioning, but they're kind of ugly masses. If they're not hyperfunctioning, then the average size is 10 cm, often local invasion. Adrenal cancer has a terrible prognosis. There's some new chemotherapy that's come along, but it's very toxic and not very good. The only cure for adrenal cancer, if it's not spread, of course, is surgery. Now, one of the things, Jason Prescott, who's our expert here in surgery, tremendous expertise in adrenal surgery, makes the point that what he wants to know, and these days, surgery has changed. So the goal is to remove the adrenal laparoscopically, okay? You do the adrenal laparoscopically, there's little complications, recovery is very good. You do a wide excision, open, is a problem. Now, sometimes you need to do an open procedure. It's not the lesion size that matters, it's concern. So if he's concerned that we're dealing with a malignancy, then you need to do an open procedure because then you need to sample the nodes and do a lot more dissection. If you know it's a benign lesion like a myelolipoma, a cyst, an adenoma, something you're removing for other reasons perhaps, or you're not sure what it is, but it kind of looks well defined, and maybe it's a hemangioma or some other lesion, but it's likely going to be benign, there's no history of malignancy, it doesn't look like a primary tumor, then he will do it laparoscopically. There's a good article, I think Steve Rowe and him are the two authors at the ends of the article, about a year ago in HAR, which spoke about adrenal laparoscopic surgery, making decisions, how you do the procedure. So as a radiologist, a big thing they want to know from me, we have our multidisciplinary conference, if I'm not sure what the lesion is, and I'm like 95% of the time certain what it is, okay, not always 95%, maybe sometimes less, sometimes more, but if I'm not sure what it is, so I think it's benign and malignant, it's a well-defined, should they do laparoscopic surgery? And we are very good. We published an article a couple of years ago that shows when we're certain a lesion's benign, it's 100% of the time benign, is that uncertainty. So I think benign and malignant, I'm usually certain. Sometimes there's stuff in between 5% of the time, which I'm just not certain. And then the question is, what do you do about that? So that becomes a very important challenge. Now let's see. This is a good time. We're a little more than about 2/3 of the way through. And if people have questions, it's a good time to ask questions. Okay, Sharik, a patient has a well-defined lesion with internal cystic area, peripheral soft tissue is thin and shows intense enhancement, otherwise normal. What's the possibility? So 110, it still could be an adenoma. If the low density measures fat, then we think about a myelolipoma. But let's say it just measures like 20 or 30. 110 is still probably going to be an adenoma, but I would be careful and make sure we're not dealing with a pheochromocytoma. You might consider when things get to be 110 is kind of high, you might get some epinephrines. It may be easy enough to do if the patient's hypertensive. It's easy enough to get a few lab values. So I think what you're describing is somewhere likely it's going to be an adenoma, but there is the possibility that it could be a pheochromocytoma. So the word intense enhancement always is, to me, means more, like 150, but 110, again, I said 120 and above is surely a pheo. 110 to 120, it kind of gets a little fuzzy there because in our experience, most adenomas are 60, 70, 80. So that becomes, I would get lab values. That's the easiest thing to do. And then you could really not worry too much. Let me see now. Alberto has a question about PE studies, but you have to ask PE study questions when we're doing PEs. I have patients that will not fill the pulmonary despite SVC right side. Okay, what's happening there? Well, it's obese patients, it's true, and it's patients who probably are valsalving during the study, which seems to be young patients or obese patients tend to do more frequently. So what I would end up doing with this patient is when you have these large patients, have them breathe shallow. Don't have them take a deep breath. It's that deep breath in the valsalva, you get all the contrast, you get all the blood on a pacifier below coming up into the IVC, and that's what's giving you your problem. So, okay, what else? Anything else on any other adrenal-related questions? Several other points in terms of adrenals. There was just a recent article making the point that if they have bilateral adrenal lesions, it's still likely they're going to be benign. So we always think about bilateral Mets, 10% pheochromocytomas, 0.5% of lymphoma, big bulky lesions. But the truth is, most of the time you have bilateral lesions, they're going to be adenomas as well. So the same rule applies. No known malignancy, low attenuation, just don't really worry about it. And then Sharik does answer back, he asked for the labs. That's the right thing to do. The labs are easy enough to get. And at 110, it makes me concerned enough that it could be a pheo. So I think with adrenals, one of the things we do learn is I think people tend often to kind of always not be certain about how to make the reports. I think one of the things that drives referring clinicians crazy is when people start talking about can't rule out Mets. Now, I guess it is possible to have a Met to the adrenal being the first presentation. Now, I've seen a couple of cases of spontaneous adrenal hemorrhage. Remember, hemorrhage usually is patient on Coumadin, or it's trauma, or it's liver surgery, something like that. But you can see hemorrhage in an underlying mass. One of the most common, again, you get myelolipomas, would be metastasis to the adrenal. And I saw several cases of adrenal hemorrhage, coincidentally right-sided. One was an underlying carcinoma, and a couple have been metastasis, typically lung cancer. So if I see bleeding in a lesion and it's not trauma and it's not surgery and the patient is not anticoagulated, then I'm going to be thinking, could this be a Met that bled or a primary tumor? Then you would look at the chest, as the lung is going to be the most common to create that problem. Let me see what else in terms of adrenals. Adrenal protocols, a good one helpful hint is, when you look, it says rule out pheo, patient's hypertensive. If you do the non-contrast first, is what you're supposed to do, and you don't see an adrenal mass, then you need to make certain that when you do the early phase, which is typically 60, and surely if you're thinking of pheos, maybe 30, is scan the whole way through the pelvis. Now, remember, 10% of pheos are extra-adrenal. So I saw a case, we've all seen cases where the adrenals look fine. Patient has a lesion of the organ of circumcondylar, which is aortic bifurcation. So you need to make certain you're scanning through there. Also, I scanned through the pelvis because I've seen cases where they scan through the organ of circumcondylar, still nothing, and then the lesion was in the bladder. Looks just like a bladder cancer. but you can have bladder pheos. So when you're looking for a pheo and you don't see anything in non-contrast in the adrenals, scan from diaphragm down through the symphysis. Now, it's true you can have extra-adrenal pheos that aren't in the abdomen or pelvis. They could be in the heart. That was reported. In the chest. So there are other possibilities, but from a get-go, that's the best way of doing it. So I think that becomes very, very important. So on the protocol side, there's something to think about. Let's see, Hassan, thank you, Professor. I've learned a lot from your lectures. Well, we appreciate that. And I'm recording some more lectures today. We have recorded 12 brand new lectures. It's 4 lectures with 3 parts, but they're terrific. And actually the first lecture, I'm trying to look at the wall here. I think today is the first PE lecture, or next week is the first PE lecture. We have the world famous Pam Johnson doing a 3-part series on pulmonary emboli. It took us like about a year to get Pam to do the talk. We threatened that she would get no free chocolates from the lab. She eats the bittersweet chocolate. We threatened to wipe out her card so she couldn't get in the lab and get the free chocolate. Not that we have a lot of free chocolate, but the free chocolate she takes, she couldn't get. And we were about to impose that threat. And the last second she recorded. But it's 3 terrific lectures, so hopefully they're coming up the early part of this year. And then we have talks. I'm looking at across the room where we have it. We have parenchymal liver disease. I think it's a terrific series of talks. And we have spleen. And what am I looking at? There's something, small bowel tumors. I'm trying to look across where Hannah is. It's on her wall, all of the stuff that's coming up. And then I'm recording some lectures today. And I can't really tell you what I'm recording because Hannah has the list I gave her. And whatever she puts up, that's what I'm going to record. But we have a lot of new lectures coming out. So, and some of the ones we've redone, like small bowel tumors was redone with a lot of cinematic rendering. So that's pretty good. So let me see, Sharik, one basic question. When measuring absolute washout, how much a region of interest should we cover? I like to do about a centimeter. You got to be careful and maybe I'll measure in a few places. Of course, if there's low density central, you want to measure that. Maybe it's fat, but you want to measure around. 1 cm works well. Sometimes people talk about larger cursors. I always find 1 cm works well. It's very reproducible. So anyway, that seems to not be too much of a problem. As I mentioned, if you go to CTisus, there's a lot of good cases in the teaching file on adrenals. We have an adrenal app on the App Store, which is a checklist on how to evaluate the adrenal glands. It's terrific. I know it's terrific. I did it myself. It's about a year old. We're going to update it, but it's really good. And then, of course, we have lectures. There's a new set of lectures in the January edition of the lecture series. It's on CTisus already, but it'll be on the new app. So I think that's really worthwhile. So with that, I think my time is up. I appreciate everybody's attention. I hope you have a great day, and we'll see you again next week. And again, it's only a 2-day week, so it's like a piece of cake. 2 days, you're off again. Soon, it'll be like nobody will be working. It'll be like Wally. Nobody works anymore. Anyway, I don't think that's happening anytime soon. AI still has a way to go. And with that, have a great day.